welcome in everybody. It's Dr. Tim Brown, your host for Pharmcast for the community. As always, sponsored by the University of Georgia's College of Pharmacy. I want to take a minute and say thank everybody for this past year. We just ended our academic year in May, and our students have graduated and go on to residencies in their careers. And it's been an incredible, amazing 12 months, truthfully, from last year to this year. But I'm going to take a little break over the summer. We're going to regroup on the Pharmcast, looking at different ways to bring you more information starting in September, as our students come back to us in August and September to start their year. But until we get to then, I have one last podcast I wanted to do, and I really wanted to center it around men's health. Back in November, Dr. Young and I got together and talked about this with Dr. Coburn, and we talked about men's health, and it's called Movember, back in November. It was really about preventive health. However, most people don't realize that June, while also Pride Month for LGBTQ population, I want to do something with men's health, which I think we could include everybody in this that certainly identifies as a man, and talk about what we should be doing to keep ourselves healthy. Because let's face reality sometime, guys, we don't do the best at watching what we do. We rely on people around us to sort of keep us on track, and sometimes we need a little bit of a push. And to help me do that, and picking back up from where we were in November, Dr. Henry Young is back with me today. Dr. Young, how are you?
I am doing wonderful. Thank you so much for having me on your podcast today.
I loved having you guys. It was such a great conversation. Can you remind the audience about your role at UGA and a little bit about your background?
Yes. So I am a department head and an associate professor in the clinical and administrative pharmacy department here at the University of Georgia College of Pharmacy. I'm a behavioral and social scientist. As my background, my expertise is in health services, and my research interests really center in on studying medication use, how folks use medications safely and appropriately, health communication and interactions with healthcare professionals, as well as health outcomes. And I particularly like to focus in on minority and underserved populations.
Thank you. And I actually want to talk a little bit, as I grouped all men under one umbrella, I do want to talk a little bit about different populations and different ethnicities, because there are stigmas and stereotypes that we need to break apart here. One of the things I was reading as I got ready for you and I to speak is I don't think I knew this, but I knew men didn't live as long as women, but I didn't realize that gap is widening, that men are dying at a much younger age and women are dying at a much older age, so that the gap between the sexes has widened. Why is that?
Yeah, there are a couple of different factors, and I think some of the top ones that are up there on the board are cardiovascular disease, heart disease, cancers, and unintentional injuries.
So can we talk a little bit about cardiovascular disease for a minute?
Yeah, absolutely.
I think, cardiovascular is this big, long word, and people are like, what? I'm fine. But really, if you take that, it's like heart disease and strokes and cholesterol and blood, all the things that we do every day we're worried about, but we just don't realize it falls under that big old umbrella of cardiovascular disease, which is a very, very broad term. So I know this. Right now, we talk a lot about cardiovascular disease in the different sexes, but men have a higher incidence of heart attacks and strokes and those. Why is that? What are the risk factors that men have that women don't?
Whoa, so I want to go to what we tend to term as healthy behaviors.
Right? Oh, okay. All right.
So when we do things, we might not eat the best. We might not have as much physical activity as we need to have. But we also may not go and, do and enact regular kind of healthcare type things. We may not go to the doctor as often. We may not get, the screenings and get the checks that we need. We take our cars in to get oil changes. We know they have maintenance.
Right.
We may not perform the maintenance for ourselves. We need our blood pressure read, and to have that information. We need to know what our cholesterol is. We need to know, how our blood sugar is working. These are all those specific parameters within ourselves to to tell us how we're doing. And we need to go and do that in annual wellness checks.
I have to admit, I hate it. I go every October, and my primary care physician is a nice, wonderful, great guy. But I know he's going to order me to go to the lab. So now I got time out of my day. I got to go sit in the lab. Then they got to poke my arm, and they take like 9,000 vials. And I'm like, why can't you just use one? And then I have to wait a week to hear if the good news or the bad news. Did that cheeseburger from McDonald's show up?
Yeah.
So it's scary. I think the one thing that you said that really hits home with me, though, is it's maintenance, right? I need to know if I'm doing something wrong or if something's kind of out of whack, so it can be addressed as early as possible so it doesn't lead to complications. Like you said, if there's not enough oil in the car, eventually it's going to impact the engine. That's
absolutely. So, using that analogy, right? So it's good for us to change the oil now, because if we don't change the oil and we continue letting that oil go and get bad, we're gonna have to change the engine later on down the road. Yeah. And we know that changing that engine is a whole lot more expensive than if we would have just got our oil changed earlier.
So those 15 minutes sitting there waiting for your labs is far better than the 6 weeks you're laid up after your heart attack.
Absolutely.
Yeah, that's true. I don't think a lot of people realize this. There are actually scoring systems to kind of tell you what your risk looks like. These make me so uncomfortable because I'm like, oh gosh, what? Because it actually predicts when they think your percentage of when you might pass away compared to the next guy standing beside you that's the same age.
Yeah.
Can we talk about that? 'Cause I think most primary care docs talk about this, but they don't really explain it to people.
Yeah, so that risk, there's a risk out there, a system is called the ASCVD score, atherosclerotic cardiovascular disease. And I know I'm bad with those fancy names and I'm gonna butcher them, right?
It's predicting the chance for your vessels to throw something and cause a heart attack or stroke, basically, right? I mean, that's what that means, that arteriosclerotic stuff, that's what that means. Yeah.
Yes. And it's based upon certain risk factors.
Okay.
Because over time, we have enough data to where we can go back and we can say, hey, what are those risk factors that impact these cardiovascular events, these heart attacks, right? So, we look at things such as age, race, gender, how much cholesterol, overall cholesterol. Cholesterol, you got two different, LDL and HDL.
Yeah.
The ADL is that bad stuff. We need that bad stuff down.
Right.
Blood pressure is there, right? Our use of medications for blood pressure, our use of medications for diabetes, if we have diabetes, right?
Right.
And also smoking.
Yeah, smoking. So, that's diabetes is a big, and I think I read a statistic once that 40% of people who have type 2 diabetes would not have it if they lost weight or their diet changed a little bit.
No, we go back to those are those healthy behaviors.
Holy cow. I mean, imagine if your diabetes this year, but you lost weight and all of a sudden you didn't have your high sugars in it. Imagine the relief of not having to deal with that. And then you said smoking, one of the biggest modifiable risk factors we all have. And I think everybody's like, oh, I gave up cigarettes. I only vape now.
No, vape, yeah.
Vaping's just as bad. If it has nicotine in it, it has nicotine in it, right?
Absolutely.
Yeah.
Absolutely.
Yeah. As a pharmacist, I have to really break this in for a second, because you talked a little bit about LDL and blood pressure. And there are medications that really, truthfully, if you're diagnosed with those, they have shown to prolong your life if you take them. So, a good example, we talked about blood pressure. Do we have some medications out there like beta blockers, which is metoprolol, or ACE inhibitors, which is like enalapril, even hydrochlorothiazide, which is a water pill. Those have actually shown that if you keep your blood pressure less than 130/80, you live longer.
Yes.
But I'm going to ask this question, if you're as bad as I am. Do you remember your medications every day? Because I have to sit mine. I take 3 things, so it's not, but I have to sit them out in the morning when I walk downstairs. Otherwise, I have to admit, if I'm on vacation and my day's off whack, I have to catch myself.
I'm smiling because, that's one of my passions, right? How do we help, improve that safe and appropriate use of medications? And, one of the concepts that you're keying in on is what we call medication adherence, right? Taking that medication as we're supposed to. It's not going to work if we don't take it. So one of the things we have to do is, we know ourselves. We have to try to figure out what sort of barriers we may encounter, which will prevent us from taking these medications.
Yeah, I get that.
Right. And then we have to develop little systems, little tricks for us. I take a medication. I have hypertension, right? So I have to remind myself, hey, where am I going to put this medication so I can see it in the morning, on my daily routine. Other folks might have other barriers. It might be cost, right? So we have to find, strategies to help folks overcome those barriers. When we're using medications to treat these underlying conditions, we need to know kind of like 3 areas. So A, what is this medication? What are we using it for, right? B, how do we use it, right? And then 3, what are some of the things that we can expect? So, how's it supposed to work? Is it lowering? Am I getting the outcomes that I want to get?
Right.
But then also, what are some of the things that we need to look out for, some of those side effects that may come into play? And then have that open communication with our pharmacists, with our doctors about, how we're using these medications and is it being effective?
Well, it's funny because when I was in practice in primary care, I would start a new medication and I would say to the patient, here's what you can expect. I'm not trying to scare you, but I don't want you to come back in 2 weeks from now and go, Dr. Brown, I hate your guts. That caused this. I want to prepare you. And if it doesn't happen, awesome. If it does happen, then you know that it was meant to be and it's not causing something that wasn't expected.
Yes.
You said something earlier that sort of resonates with me too, is when you're talking about these things and how to take them and sort of having your own triggers, a lot of these things don't hurt. Like I can't feel my high blood pressure necessarily. I certainly can't feel my LDL being elevated. Now, if you have sugars, that's a little bit different. You can feel that. But a lot of people, don't think about taking medication because it doesn't hurt or inconvenience them. But if I have heartburn, I'm going to take a heartburn medication to get rid of it, right? If my big toe hurts, I'm going to take a Tylenol. But I can't feel my blood pressure. So sometimes that doesn't really play into a trigger, if you will.
Yeah.
So, go ahead, please.
And that's all a part of being that active participant in your care, right? Your healthcare providers and professionals, they only see you but so often. You are going to have to be your own self-manager of your health and your healthcare. Yeah, and you have to be. You said about cost. You're going to have to be the person that speaks up and says, "Listen, $10 a month, I can't pull this off." And absolutely, and just say it. I mean, because if you don't say it, no one has a clue. Right. It's funny. I had to go this morning to one of my doctors, and the copay was astronomical. And I prepare for it. I save for it. I walk in the door knowing it. But at some point, I could call and go, that's not going to work for me. What can we do? Do you want to talk to me over the phone? Can I tell you what's going on? Because sometimes it's gas in my car or food on my table, and we don't have money. Yeah. Stuff. Yeah. And if it's not bothering me, why do I need to buy a drug? That's my dad says it's, well, if I can't feel it, I'm fine. I don't need anything for that. It's so hard getting that through to him. Yeah. That preventive thing that you talked about. Mm-hmm. Mm-hmm. It's often challenging for us to, if we're not feeling it, if it's not here and now, oftentimes we have to experience things through others' eyes. We call it vicariously living, in order for us to realize that, hey, this is something that we're going to have to take care of. So can I ask a personal question? Yes. You don't mind? You mentioned you had high blood pressure. Yeah. Now, as a Black man, your risk for strokes and heart attacks and even kidney disease is higher than someone who isn't Black. Absolutely. Does that drive you to be better about taking your medications? It does, but I'm going to throw in another factor on top of it. Yeah. Family history. Got it. So my dad, he was obese. He had high blood pressure. He was a diabetic. He had mental health issues. He had heart failure. He had kidney disease. What else? He had some lung function stuff because he was a smoker. Got it. I call it the classic African-American comorbidities. So seeing him, and he was an alcoholic and drug addict. So he had substance use disorder. So seeing him and living vicariously through him, I saw some of the challenges, some of the struggles that he went through. My dad passed away at an early age. So that really impacted, hey, I need to take care of myself. I need to walk. I need to go to the gym. I need to exercise. I need to get out. I need to do something that'll take my mind away. Right.
Right.
Because that mental health component is something serious.
Right. And, mentally, when you're mentally healthy, it's easier to be physically healthy, right? Because you can focus. That's a really good point. And family history is, I don't think people ought to think about family history and history repeating itself. But the way your grandparents died or the way your parents may have passed away, that actually could have an impact on what takes you out on this world.
Absolutely.
And none of us want to think about that, right? Because we don't want to think about our own mortality, but and so it's a big deal. We were talking about meds earlier, and I think one of the meds that I hear people say they don't take a lot are statins, like Lipitor, Crestor, atorvastatin, all those kinds for cholesterol. I don't know if people realize that the amount of data out there about how they actually make you live longer it's pretty astounding.
Yes, it is.
My grandfather and great-grandfather didn't have statins, and they both died of heart attacks. Mm-hmm. So they didn't have a drug that would lower their cholesterol. It wasn't around.
Right.
So you're right. Family history plays a role. And then we have to say to ourselves, I have an iPhone. My granddad didn't. I can call Uber Eats at 3 a.m. if I'm hungry. My grandfather couldn't. The same is true for medical technology, right? We have Absolutely. Drugs now that, so we're throwing it away if we don't take advantage of it.
Use the technology.
Yeah.
Use what we have. And drugs are technology, right? It's scientific stuff that goes into those little pills. I'd say the cell phone is a perfect example. Do you remember way back when we had to go to AAA and get the maps out and plot out our trip on the map?
Oh, yes. I remember having the books for each city and having the map pulled out. Yeah.
And pulling it out. Right. So I remember it, as a kid and, taking family trips. Fast forward through some time, do you remember getting online and finding MapQuest?
Right.
And then MapQuesting your destination and then printing that out?
I do.
Right. Fast forward to today, we can enter in GPS with our cell phones, or some of our cars might have that capability. This new technology makes things a little bit better for us. Right. So, it is just out
it also
there.
Gives us information that I think we should have discussed. Like if you read something, you're like, I don't know if I like this. Don't take that at face value. Bring that back up with your healthcare provider, because some of the stuff is not accurate. Some of the stuff may only pertain to you as a patient, but doesn't pertain to me.
I wholeheartedly believe. Yeah, thank you for bringing that out, because we're in the age of Google, and information overload is just out there.
I agree.
So, we have to be very cautious about the sources of information out there on the internet.
Well,
and you said it. Talk to your healthcare provider.
Yeah, that brings a really good point. Aspirin. For years, I was told that you should take an aspirin a day. It'll be better for you, blah, blah, blah. We now know that's not true. That you should not take an aspirin a day unless you've had a heart attack or stroke or some issues. But if I've had nothing happen, by the grace of goodness, there's no wood around me to knock.
Right.
So I shouldn't be, that's completely new in the last 5, maybe 8 years, that maybe your dad took an aspirin a day, but now you're like, well, dad took one every day. I should do that. In other words, medicine doesn't stay the same.
It changes, right? And I think that was one of the toughest things for people to get around, especially dealing with COVID, because COVID was new. The state of the art was changing constantly.
True.
We did so much research in such little bit of time. The evidence that we were compiling was changing. We were basing decisions upon what we knew, the evidence base. Evidence change. So, we have to adapt. We have to change the evidence.
Well, and how quickly that, as you talked about, there used to be we didn't see a clinical trial for 5 years after it was done because it took forever for everybody to get to it and read it. Now I can Google the sucker and have it up in five. We can all read it on our phones while we're,
Yes.
the same is true for anybody out there with anything. That brings me to another thing. You talked earlier about cardiovascular disease. The second thing that you talked about that makes men kind of leave this world a little quicker than women, cancer. And the screening ages have changed dramatically.
Yeah.
So, okay, for dudes out there, think about it. What cancers take us out? Well, prostate, because we have a prostate and women don't. Lung, colon, bladder, and the one no one thinks about, which as a white Irish light-eyed dude, I am learning about right now from all the time I spent in the sun not paying attention to my mother telling me to put sunscreen on. Skin cancer is a big deal for
Absolutely.
We thought it was not a manly thing to do to put sunscreen on, and
even for us folks with melanin, or a little bit more melanin, we have to be aware of it as well. I just at my last annual wellness visit, I let the doctor know, hey, I'm noticing this thing on my foot. So she looked at it, it was a mole, it was getting a little big. So she said, I'm going to refer you to the dermatologist. Went to the dermatologist, and the dermatologist said, yeah, we're going to go ahead and take that. Just because we wanted to, make sure that, it's not cancer.
Right.
So I said, yeah, let's go ahead and take that.
Let's make sure that's a good idea. I like that.
That's a good idea. Let's go ahead.
So now we got guys saying, wait a minute, you just told me I got to go to my primary care. And now you told me I got to go to the next person because they found something. It's true. And I hate to break it to you guys, but as we age, you're going to know a lot more healthcare professionals. I have found with every decade, I meet a new one. In my 20s, I had my primary care doc. That's all I needed. I hit my 30s, I had my primary care doc, and then I had a specialist. It just keeps moving forward. Prostate cancer, it impacts African-American men at a higher instance than other men.
Yes, it does.
But so they move the screenings around, right? When should you get your first prostate screening with the new guidelines? You remember?
I think we're around 40.
Okay.
Yeah, around 40.
So that means prostate screenings, guys, mean that they run a test called a PSA. And sometimes they have to do what we call a digital rectal exam, DRE, but get over it. Come on. You've been so drunk you fall down and smacked your head on the pavement. You'll be fine with a DRE. I love it when men are like, I'm a man. Oh, no, we're not doing that. I go, dude, prostate cancer are 2 seconds of just let it happen.
Yes.
And then they screen that pretty rarely. But if you have a family history, they're pretty good about follow-up on that too. Because I know that with African-American men, if there's a father that had prostate cancer, they're really aggressive about watching to make sure. Is that fair?
Yes, that is absolutely fair. And you want to get a prevention, but then early detection.
Yeah. Because early detection, the success is pretty amazing, right?
Yes. You have a much higher chance of getting through it if it's detected earlier.
Yeah.
With cancers.
That's the one that, guys with a prostate, they can identify with this, obviously, because it's almost like women with breast cancer. Although men can get breast cancer as well, it's not as prevalent, and we certainly don't do mammograms on a routine basis. But prostate cancer is that holy male discussion about that gland that can turn to a cancer. But if caught early, knock it out, it moves.
Absolutely.
The other thing sort of everybody shares is colon cancer. And the screenings, the age changed there too. It just got younger, right?
45?
Yeah, it was 50. Then I think they had 45 for African-American population. And then they realized that it was too confusing. So now everybody, I think you should get your first colonoscopy at 45 or your first colon cancer screening. There are different ways to do it. Colonoscopy is the gold standard.
Yep.
Yeah. It's interesting because I have people ask me about this all the time, like, is it inconvenient? And I go, to be fair, if somebody who's actually past the age of 45, they knocked me out. I had a great nap. I didn't even know what happened.
So I am 47 and I had one. They put me out.
Yeah.
I had no idea what happened. And I woke up and it was A-okay.
They said, well, welcome back, Dr. Young.
Yes.
I'm telling you that I let my brain get ahead of me and worry about it. more than I should have, because it was probably one of the easiest things I ever did, because they made me so comfortable. The people who worked. So, if you guys are worried about that, make sure you've got to have your prostate checked if you're looking at the age of 40 and older. And if you have family history, even sooner. And then 45, you need to be screened for colon cancer. And that's between you and your primary care provider, which how many, and you guys answer this yourselves, how many of you guys right now have a primary care provider that you see routinely that you know and like? Because don't wait until you need this. Find somebody you like and establish care, because there's nothing more frustrating than waiting 6 months to get the appointment, and that brand new person sends you to 9 other people to get all this stuff done because you're behind.
Yes, absolutely.
We talked about smoking earlier. One of the newer recommendations is if you are a smoker or a past smoker, they may want to look at your lungs now. That's not for everybody, but that's newer, right?
Yeah, it is. It is. And again, it's all in this early detection.
Yeah.
Can we catch it early?
Yeah. It's interesting you say that, because it was once thought, oh, we don't have to worry about that, not look at it. But now with treatment and technology and the surgical intervention, the earlier you come across things that are wrong, like a small place on your lung, it can be changed and rectified, where 15 years ago, there was nothing, we didn't screen for it because there was nothing to do for it.
Right.
It's amazing. I think the last one, we talked about this already with skin cancer, going in annually, talked about your foot. I had 2 areas on my chest where, sitting out in the sun lifeguarding when I was a teenager, being red, it's the area that got burnt the most. Let me tell you, I now look back and go, that sunscreen didn't look half bad. I should put that on. Hindsight's 2020, gentlemen. I was like, when they, and that one didn't bother me, but the healing process bothered me. I couldn't move my arm without hurting the wound. I'm like, if I had just followed the rules.
I wanted to let you all know out there too, in this podcast land, sunscreen and sun protection is good for African Americans and folks with darker skin as well.
So I actually had a PharmD dermatologist on last month. If you guys have not heard that podcast, go back and listen to her. She works for dermatology out of Emory, and she is incredible. And she talks about how all skin tones, colors need to protect themselves. And she talks about which SPF to use, why we do it. She's awesome. So pop back over and look at that podcast previous to this. She rocks it, man. I'm so pleased to see a pharmacist working in dermatology to help with stuff like that.
Absolutely.
So this brings, we talked about prostate, talked about colon cancer, talked about skin, but there's also
testicular.
Yeah. I talked about mammograms earlier, and women do self-breast exams. The equivalent for our side are actually self-testicular exams.
Yes.
So can we review how to do a self-testicular exam? Because I think a lot of guys are like, this sounds weird, but really it's not. It's kind of simple and straightforward.
Yep. And, you can do it often. I think one of the numbers, like 1 in every 250 males might experience testicular cancer. And, we can do it standing in front of a mirror.
Yeah.
Checking for swollen areas or around our scrotal skin, or, even in the shower, we can do some of the things in the shower. We can examine, hold the testicles between our fingers and thumbs and roll them gently to see if we're noticing any lumps or any nodules, any things that are just inconsistently done. And, I would say, even if you don't, start now, because you can feel what it feels like now.
Yeah.
And if we notice a change.
This is something that my friends who are women have taught me. Everyone's breast tissue may feel different. So knowing what your baseline breast tissue feels like lets you feel if something is wrong as you age. So starting now lets you feel what's normal for you.
Yes.
And that's also true for these, like your skin. Watching your skin with mirrors, looking at this and paying attention to the areas that may look odd. You can do all this at the same time every month. You can do a skin check in the mirrors, and then you can do your self-testicular exam and sort of make it the 15th of every month. I don't know.
Yes.
Make it your night.
Yes.
Light a candle, draw a bath.
Right.
It's your night. But your point is, if you feel anything off, it doesn't feel quite right, it's different than last month, that needs to be looked at fairly quickly.
Absolutely.
Yeah. Yeah. I think the other thing that people don't realize is testicles in general should feel smooth. There shouldn't be lumps and bumps. And if you feel that you really, or if you have symptoms like where you can't pee very well or things aren't working well sexually, you need to get in and have that examined to make sure.
Absolutely.
Well, and that brings me to, that's self-help, getting there. And we talked about taking medications, but where men are even worse? Getting their shots.
And what you mean by shots, you mean those vaccines?
Yes.
Adult vaccinations. Yep.
We got them as kids and we think, oh, we're impervious. We don't need anything else. But there are vaccines now that didn't even exist as a kid that I wish had existed.
Yep.
I wish there had been a chickenpox vaccine when I was a kid. But so I think the other thing too is talk about when you go in, you should be looking to make sure you're up to speed on your vaccines, right? Not just the flu, which is important, but others.
Mm-hmm. Mm-hmm. Yeah, there's a list of those adult vaccinations, HPV, Hep C, pneumococcal, tetanus, shingles if you're over 50, that flu vaccine. These are all tools in that toolkit that we can use to ensure that we stay healthy.
Interesting you bring that up. The one vaccine that kind of resonates with me is the HPV vaccine, because it prevents cancers.
Yep.
And they started out giving it to people that were younger, and they've now progressed up to almost, I think, the age of, it might be in your 40s now. I have to go back and look. But if you're someone out there and you think about this, because it stops penile cancers, rectal cancers, obviously cervical cancer for women. That's something that is such a brand new thought process that many of us don't even know it's out there. And then the other thing I'll tell you up front, hepatitis B.
Yes.
If you were born after 1990, they didn't give it to you at birth. And I'm going to share a thought with you that is just dead on. Hepatitis B is one of the highest sexually transmitted illnesses that we have. It is a mean virus. It's worse than HIV by far in terms of transmission. And we have a vaccine for it. And if you don't know that, you need to talk to your primary care, especially if you're out there having sex, you're not being monogamous. You need to, that's one, the HPV and the Hep B. If you're sexually active and not being monogamous, holy cow, you should be looking at these.
Mm-hmm. Absolutely.
You brought up the shingles vaccine. Man, that has changed the way we look at the chickenpox virus, right? Because the chickenpox virus is the one that gave us that.
Yep.
And it sits around, and all of a sudden we get stressed, when you're chair of a department, you have that highfalutin job like you. Because that shingles comes back. If anybody's ever seen a shingles outbreak, I would be running to the nearest drugstore, doctor's office I could find and be like, give me this vaccine.
Yes.
So if you're 50 and above, don't forget that that's out there too. I'm harping on this because I said something to my dad recently about vaccines. He's in his 70s and he looked at me and goes, I got all my vaccines when I was a kid. The concept of him going back to get a vaccine.
It's not there.
Right. So I just want you guys to think about this when you're in that office to if they say you need it, if you need this, go for it. Yeah. One of the areas that you said earlier about how we die faster, the third area is unintentional. And that, I don't know what that means. It's unintentional death. I think in my world, I'm thinking, okay, define unintentional death. Like, why do we as men die faster from this vague term?
So, yeah, it is a vague term, right? So we have all these fancy falutin terms for different things. So we're talking about motor vehicle accidents, falls, overdose, deaths, things of that nature.
Yeah, I didn't even think about. So overdose, golly, you want to talk about in the past, 10 years, the number of fatal overdoses that we've seen?
Yes.
I didn't realize that was more of an impact with men. But yeah, I mean, I can see how our death rate, that widening gap we talked about earlier, that may have a role in that too.
Mm-hmm.
Do you remember that University of Georgia, we did that big programming about how to keep your friends and family safe if they're using narcotics?
Oh yeah.
You remember that?
Yep.
Yeah. So I don't think a lot of you guys know there's a rescue medication that if you have a relative that's using, even if it's prescribed and you're using it the way you should use it, they still say you should put this drug in your house. If you have a relative or someone that's misusing narcotics, you definitely want to put this in your house. It's a drug called Naloxone, right, Dr. Young?
Absolutely. Yes. One of the life-saving strategies out there, right? So if, there are certain signs and symptoms that, someone might be going through, and, you pull out the naloxone, it just depends upon, the form that you get. But that medication can help save lives.
It reverses like heroin, fentanyl, OxyContin, Percocets. It reverses them, right? I mean,
Absolutely.
Holy cow. Talk about mind blowing in terms of what you now have access to, that if someone overdoses or they get too much medicine, so they actually say, talk to your primary care doc, even if you're not the one using, you can be the person who carries it for them.
Absolutely.
And I think some pharmacies you can walk in and pay cash, and it's, depending on which form you get, not horribly expensive.
Yep. You can absolutely, right now it's available through the community pharmacies.
Yeah. I stress this, that sometimes it's not the person using, it's the people around them. So if you're listening to this, you think, I don't have that problem. Yeah. I get it. But if one of your kids, your spouse, your parents, if anybody's using narcotics, this is a great discussion point with your providers to figure out if you need to be that safety net.
Absolutely.
That's a,
and you mentioned, prescription opioids, right? Yeah. If you're using prescription opioids and you might take, an extra one or something, it's good to have it just as a safety valve.
Yeah, I agree. And so prescription opioids, just so you guys know, Vicodin, hydrocodone, Tylenol #3, OxyContin, oxycodone, Percocet. Those are the ones we're talking about. And they are, a lot of people have them in their medicine cabinets. I mean, they do. After knee surgery, a lot of people get, I'm not really calling people up knee surgery. It's just the one that hits my mind. A lot of people who get orthopedic surgeries tend to have a short course of this afterwards.
Yes.
That sort of goes along with another question I want to ask you. You mentioned alcohol misuse.
Mm-hmm.
I've talked to several people doing this podcast over the past year about COVID and how that has changed socially how we do things. So if I'm home and not in a bar, I might pour myself an extra drink that in the bar I wouldn't have had, because I don't have to drive. There's no one watching me.
And you don't have to pay for that extra drink, right?
And I can pour the amount I want.
Absolutely. Yes.
So I want to remind y'all that Dr. Tackett was on in January, Randy Tackett. He talked about how much is too much. And you want to talk about me into that podcast, giving myself a once over. I did a self-exam. I'm like, what am I doing? Is this right? Is it wrong? He was really great about framing that. Do you have friends that you think you think you got friends and you have escalated your alcohol use during COVID?
Oh, absolutely.
And mine too.
Yes.
Mine too.
Yes.
We were just talking about this the other day. I have more friends with full bars in their houses now that didn't have them before COVID. I was away this weekend with friends, and I could not believe the number of people and how much alcohol they had in their house. And we were able to go to restaurants and stuff because it had become a norm to have that at the house.
Yeah, I was just talking with a bunch of my buddies this afternoon. I mean, not this afternoon, but this past weekend. And we were talking about how our budgets changed. And, they were talking about that line item in their budget. And I said, did you shift it up?
Yeah.
For that alcohol consumption?
Yeah.
So yeah, it's definitely had an impact on the things we do.
Yeah. And I think that stems from anxiety, stress, depression, mental health. And you want to talk about a group of people who refuse to believe they need help.
Oh, absolutely. Us. Yeah. We don't need that.
I'll wake up tomorrow. We'll get through this.
Absolutely.
Yeah.
Absolutely.
Have you seen the commercials?
Which ones?
So there's two that there's one that's skydiving and his parachute it doesn't open. And the lady behind him says, grab onto me. I'll help you. And the guy goes, oh, I don't want to ruin your experience. I'll be fine. And I'm like, the dude's in a free fall towards Earth. There's nothing that's going to stop his impact except this lady. Instead of taking her help, he goes, oh, I got this. I'm a man. I'll be fine. And then the other is a guy on a bench. He's trying to bench press. And something happens. It won't go up. And a guy comes over and says, can I help you? And he goes, no, you don't know my family. Don't help me. And man, you want to talk about one that hit home, because our grandparents and maybe even our parents are like, you did what? You're on what for what? Now pull yourself up and get on with it.
Absolutely.
We have to fight that, right? I mean, you can't let what they consider to be mental health impact what you do to get your care. It scares me that when people
You
stop
know,
others.
there's so much stigma
Yeah.
and just bad thoughts. I mean, we have to catch ourselves too, because when we see folks out there dealing with mental issues and mental challenges, you know, I can, all right, so I'm gonna admit this. Back when I was in high school, there's that hall and we didn't necessarily treat, folks who are in those special needs classes
Right.
appropriately. Folks have challenges and
Yes.
we need to have a little bit more compassion about those challenges. So not only, give out those negative kind of attitudes and things, have some compassion, have some feeling.
And I think we have to normalize it's okay for men to seek help.
Oh, absolutely.
With their mental I won't say illness, just mental. I mean, like sometimes it drives me crazy when I'm talking to people and they're like, no, I'll get over it. It'll be fine. And I'm like, will it?
Yeah.
You haven't been yourself for 2 months.
Yes.
Everybody around you is miserable because you're miserable.
Yeah.
They're all worried sick about you and you're being a jackass about going to see somebody.
Yeah.
Yeah.
I think you hit on an important topic too, because as men, we have friends. We see our friends struggling.
Yes.
Reach out and talk to your friend.
And let them know it's okay.
And let them know, absolutely.
Yeah, I'm with you. I have a good friend right now that is going through post-COVID, incredibly depressed, can't get his health back.
Mm-hmm.
And we talked about him going to see somebody. He goes, oh, I did. I went over and I saw my primary care again. I go, no, you need to be in with somebody who can talk to you and let you process this. Heck, go in and just spend 15 minutes yelling and being so frustrated.
Absolutely.
When you're considered to be the strong one, which so many men feel they are, it's hard for them to admit they need somebody to sort of help them get through a rough time.
Absolutely. I don't know. And it is so important for us to do it. Suicide is out there.
Yeah.
And suicide is
what I read here it is. Dr. You're absolutely right. Dr. Young, men die by suicide 3.88 times more than women. I have that on my notes.
Yep.
And 70% of suicides in 2020 were white men with firearms, guns, accounting for 53% of those deaths.
Yes.
So not only do we know suicides out there, we know that unaliving of men faster than women, this is playing a significant rate along with the alcohol use. And, does this lead to the alcohol use or the use of a narcotic to sort of numb the pain?
It does. Yeah, we self-medicate, right?
Yeah.
We self-medicate.
I think seeking care in this, I don't know. Do you feel maybe I'm being stereotypical and I apologize. I feel like it's harder in those cultures in which the man is the hyper masculine breadwinner. They can't really be anything but.
Absolutely. Yes. Yeah.
I feel that a lot in the Black community. When I talk to my friends, I feel that a lot in the Asian community and certainly in the Latin community. I'm not sure
we're not supposed to be weak. It's being perceived as being weak.
Yeah. I mean, I certainly see it with friends that are white as well, but it's a little bit, I'll say it's hit or miss. It depends on who they grew up with and where they are. But man, I have some friends that are Black, and admitting that they are not having a good day, not going to happen. Everything, I worry sometimes about not recognizing your own need.
Yes.
Yeah, I worry about that. So we have talked a lot about men's health, prevention, that we'd like to see the gap narrow and like to live as long as our women. We'd like not to die, and leave them on their own. We've also talked about the fact that preventive health, screenings, asking for what's going on and checking yourself and being self-care. And then the last one, of course, is asking for help when you need help, no matter how that defines. So we've covered a lot. As always, you bring such great insight. Your background in the disparities and what happens with healthcare is astounding. Can you give our audience 3 takeaways for the last podcast of this academic year? What would you have?
May I have 4?
You can have as many as you want. How can I say no to a guest like you?
Thank you. This and what I want to say is it's all wrapped up within one concept. Dr. Hibbert and her colleagues, they developed or came up with this conceptualization of an active patient or patient activation.
Okay.
So, I want to encourage everybody to be an active member or active participant in their own healthcare. And what that means is, one, you have to, come to terms that, hey, your role in taking care of yourself is important. You got to have that attitude, right? Then you have to have the confidence and the knowledge to empower yourself to take action in doing those things. So not only having the attitude, but you got to have some knowledge and some confidence in your abilities to do it. Then you also have to take action. You have to do the things that you know you need to do to improve your health and stay wealthy and stay healthy. And then finally, you got to stay the course, right? We talk about, doing some things for one thing, but no, this is something that we have to consistently do and stay that course under stress and pressure.
I think stay the course, Dr. Young, when you fall off the horse, you fall down, you don't do it the right, get back up, start over.
Back up. Absolutely.
Yeah. That's something that sticks with me all my life. My dad says you haven't failed until you stop trying.
Yes.
And that sticks with me a great deal. So that was perfect. I love that summary. And for the guys out there listening and for everybody else listening, if you have a guy in your life, this is something they need to hear. And if they're not believing you, send them to the podcast.
Yes.
Maybe we can, reaffirm what they're hearing from their relatives and those who love them.
Yes.
Until September, I will see you guys then. Dr. Young, thank you so much for coming on board and doing Men's Health Month. That was great of you.
You are so welcome. Thank you for inviting me.
Absolutely. Anytime. I will be reaching out to you again the next year. For those listening or watching, thanks for listening to Pharmcast for the Community, sponsored by the University of Georgia's College of Pharmacy. As I mentioned, we're going to take a little break, come back in September, looking at ways that we can impact your health and answer your questions. Until then, be safe, enjoy your summer, and enjoy being with your family members. Thanks again. Bye-bye.
Thank you. Bye.